Okay, we're going to see how far we can get here. I'm going to try recording the rest of chapter 62 and moving on into 63. Right. So we stopped last time with compartment syndrome, so this will be for exam 4. Upper and lower extremity injuries. Those are going to be specific injuries to upper and lower extremities, include things like tendinitis, which is broken down into epicondylitis and ganglion cysts. Then you can, carpal tunnel is also included in there. We're going to talk about rotator cuffs, ligament and meniscal injuries, fractures. Got a lot of stuff to cover. All right, so tendinitis is an inflammation of the tendon caused by overuse. So epicondylitis is actually, the actual name is epicondylitis. This is what people will often call tennis elbow. It does not have to occur from playing tennis, but it's a repetitive motion injury. So the injury occurs when the tendons of the medial or lateral, radial, and ulnar epicondyles sustain damage from excessive pronation and supination of the forearm. So that's why they call it tennis arm, because, well, where am I? It's this constant pronation, supination, like you would have when you play tennis. So they often have pain in the forearm with a very weak grasp when they have epicondylitis. Then you've got the ganglion cyst. This is a cystic mass that develops near a tendon. It is formed through defects in the tendon sheath of the joint capsule. The patient will have pain to the affected area, and I think I have a video posted on Blackboard of a ganglion cyst. Now sometimes these, I've had friends who've had ganglion cysts like on their wrist, oftentimes right up in here on the wrist, and the old school thing to get rid of a ganglion cyst was to slam a heavy book on it to actually pop the ganglion cyst. People don't really do that anymore now. If you have a ganglion cyst, they may go in and actually do surgery and remove the cyst if needed. Treatment for both include ice, heat, NSAIDs, steroids, analgesics, and rest, and sometimes surgery. All right, carpal tunnel syndrome. Carpal tunnel syndrome results from repetitive wrist motion that traumatizes the tendon sheath or ligaments in the carpal canal, producing swelling that compresses the median nerve against the carpal ligament. I'm sure many of you know people who've had carpal tunnel syndrome or carpal tunnel surgery. My father-in-law just finished having his second carpal tunnel surgery right before Christmas at the end of the year. Clients complain of pain in one or both hands radiating at the forearm or the shoulder. The pain is often worse at night and early in the morning. They wake up with severe pain, usually early in the morning. Sensation excuse me, may be lost or reduced in digits 1 through 4. Now, a lot of my family members have carpal tunnel syndrome. My husband's cousin actually just has recently in the past year had carpal tunnel surgery as well on both hands. And then my father-in-law and my husband's cousin and my husband and many other members of our family work at Toyota. And at Toyota, you do a lot of the same repetitive wrist motions, and so that's why they get this carpal tunnel syndrome. It's a very common surgery for factory workers. All right, treatment includes splinting to rest the hands and wrists, use of NSAIDs, periodic injections of corticosteroid preps, and or surgery to release the pressure of the ligament on the median nerve. Oftentimes they will have sleep in wrist braces to try to help relieve some of that pressure throughout the night with the swelling. And sometimes that will help be a temporary relief measure for them. Now there are 2 diagnostic tests. So I hope that you'll pause the video again and look this up in the book. There are 2 diagnostic tests. One of them is called Tinel's sign, and one of them is called Phelan's sign. So Tinel's sign detects irritated nerves. If the patient has carpal tunnel, the patient will have numbness and tingling if you lightly tap over the nerve. In Phelan's sign, you put your hands together for 30 to 60 seconds. The examiner applies force inward, and patients with carpal tunnel will experience numbness or tingling. Again, I think I have some videos posted on Blackboard, some YouTube videos showing Tinel's sign and Phelan's sign. So please review those as well. All right, then we've got a rotator cuff tear. This occurs from overuse or irritation of the shoulder joint, or traumatic injury. Oh. All right, diagnosis is based on examination. You have 3 signs and symptoms. And you'll have pain. If it's past the elbow, it may not be a rotator cuff tear. So if the pain is down the arm past the elbow, it may not be rotator cuff. But the diagnosis is going to be based on exam. Patient experiences pain with movement, especially when lifting their arm over their head. So when they do this, extreme excruciating pain. Severity of the injury is determined by X-ray and MRI. Okay. Treatment is going to include NSAIDs and rest. Patients are often unable to sleep on the affected side. So if I were to have a right rotator cuff tear, I would not be able to sleep on my right shoulder. The pain is much worse at night on a rotator cuff tear. If surgery is needed, the client will need to mobilize the shoulder for several days to weeks and need physical therapy. The client should have full recovery within 6 to 12 months, but 6 to 12 months is a long time. Rotator cuff tear is another surgery that a lot of factory workers have, especially if they're doing things over their heads, up and down, things like this. They will often have rotator cuff injuries. Okay, so be sure you understand causes, diagnosis, treatments, when they have pain and things like that. Ligament and meniscal injuries. These occur as a result of traumatic injury, things like ACL and MCL, your anterior cruciate ligament and your medial cruciate ligament. They occur when the client is standing firmly and receive a blow or a twist in a different direction while hyperextending the knee. The menisci can become injured, disrupting the stability of the leg when flexed or extended. So this is what happens very frequently with athletes. They often complain that their knee just gave out, or that their knee locked up, or that they hear a popping sound from the cartilage actually moving. So this, unfortunately, is a very common injury in sports like soccer. My kids play soccer, and they've had many friends with ACL tears. Happens a lot in females in particular. Has to do with the quad muscles, the strength of the quad muscles to strengthen the ligaments around the patella. Also basketball players, because they'll run and they plant and turn, and they'll have a lot of ACL tears because of that. Treatment is going to include NSAIDs and ice for the first 48 hours. And if the meniscus is actually torn, the surgeon performs a meniscotomy to remove the damaged cartilage. Recovery time is 3 to 12 months, depending upon the severity of the injury. So that's pretty significant, 3 to 12 months. And that's really been an issue for a lot of athletes in coming back. They're very timid, especially, when they come back, they don't want to re-injure. And it's a very slow, long recovery. You have to have gradual introduction into activity to prevent any type of further injury, and you'll often see them out wearing these big huge knee braces after surgery if they do come back to their sport, to try to limit any type of further damage. All right, now we're going to move on to fractures. Fractures are a break in the continuity of a bone. The blood seeps into the area of the break, a clot is formed, and over time these cells form a callus, which then stabilizes the bone. Full bone remodeling may take up to 12 months. I think that's mind-boggling, that it can take up to 12 months for it to heal. We throw a cast on somebody for 4 to 6 weeks, and then we say, okay, you're done, you're good to go. That's not the case. So education, client education is very, very important in any kind of fracture. Okay, it's going to take, like we said, 12 months to be back to, quote unquote, back to normal, for the bone to be back to normal. So they often will need to understand that there is increased risk of refracture immediately after the cast comes off. Oftentimes physicians will prescribe splints or soft casts for them to wear, if it's athletes especially, to wear when they come back to the sport, so that the risk of refracture is decreased at least a little bit. Usually fractures occur from direct blow or force, but sometimes just from strong muscle contractions themselves, like seizures, can actually cause broken bones. Sometimes you have bone infections, osteomyelitis, or bone tumors, or decreased bone density that will cause fractures. All right, let's talk about some fractures here. So different types of fractures. We've got avulsion fracture, which we already talked about a little bit, comminuted fractures, compound fractures, compression, green stick, oblique, pathologic, spiral, transverse, and depressed. Now again, I hope you'll take the time to pause the video, go through the book, and look this up. This will help you remember it way better than me just spitting out to you what it is. I am going to spit it out to you, but it will be a lot easier. It will, not easier. It will help you remember it a lot better if you'll look it up in the book as well, and then just kind of come back to the video to get confirmation. Okay, but an avulsion fracture we talked about already was where the fragment of the bone is pulled away by a ligament or tendon. The comminuted fracture is where the bone is splintered into several pieces. A compound fracture is where the damage from the bone involves the skin, so the bone actually comes through the skin, which would obviously cause a increased risk for infection. A compression fracture is when the bone is actually compressed. This would be things like a vertebral fracture. When someone jumps and they have a fracture, that's especially of this vertebrae, that would be a compression fracture. Green stick fractures often occur in pediatrics. This is where one side of the bone is broken and the other side is just bent. It's very interesting. Really only occurs in pediatric patients because their bones are still soft. They are not as calcified as adults. Oblique fractures occur at an angle across the bone. Pathologic fractures from a diseased bone. So this would be things like decreased bone density, osteoporosis, things like that. Spiral fracture is a twisting around the shaft. The fracture actually is from twisting that fractures the bone. This will occur, I don't want to say oftentimes, but when you see this, especially in pediatric patients, one of the biggest concerns is abuse. Transverse fracture is going to be straight across the bone. And a depressed fracture is a downward fracture. This would be something like a skull fracture if you got hit in the head with a blunt object and the bone is depressed. That's going to be a depressed fracture. We also had things like a stress fracture that occur from overuse. It just causes like a little crack in the bone, so it's not actually fractured all the way, but it causes cracks in the bone. Oftentimes it's not even evident on x-ray for a few weeks. So usually it's seen in the lower extremities of athletes who play high impact sports like basketball and soccer and things like that. And it happens quite often. So if someone's complaining of consistent pain, get an x-ray, nothing is showing up or anything, you know, they'll often start looking for a potential stress fracture. Excuse me. You need to be sure that you understand all of these types of fractures and the difference between them all. You know, how you classify a green stick versus a spiral fracture, or a transverse versus a depressed fracture. So be sure that you understand these types of fractures. All right, complications with fractures. Compartment syndrome is a complication of fractures, and this is something we've already talked about. Compartment syndrome is when the tissue perfusion is compromised related to swelling. So there'll be increased blood flow, increased swelling in the extremity. It will cause the tissue perfusion to be compromised or to decrease, and cause significant pressure. So what you'll want to do is elevate the extremity, do neurovascular checks, you apply ice, check for pain, and relieve by medications. All right, then we've got thromboembolism, which can lead to, obviously, pulmonary embolism, which results in anxiety and decreased O2 sats. Oftentimes these patients will get something like a low-dose heparin, especially if they're at high risk for thromboembolism, or at risk for clots. A fat embolism is most often seen after a long bone fracture. So if you've had a femur fracture, we're going to start being concerned about potential for a fat embolism. They happen with crushing injuries. You need to be sure and provide early immobilization, respiratory support such as turn, cough, and deep breathe, and monitor for respiratory distress. One of the signs and symptoms of a fat embolism is increased respiratory distress, increased respiratory rate, cyanosis, grunting, confusion, retractions, and this will usually occur within the first 48 to 72 hours after the fracture, after the long bone fracture. Okay, you've got delayed healing, which can lead to non-union or malunion. So if you have delayed healing, the bone may not fuse back together perfectly how it's supposed to go. It may be off just a little bit, and that's going to cause a problem. Infection is another complication, which obviously you have an increased risk for infection with a compound fracture. If you have skeletal traction where the pins are in the bone, we're going to have an increased risk for infection. Or if you had any kind of surgical procedure for the bone, you're going to have an increased risk for infection. Avascular necrosis is the death of the bone from insufficient blood supply. This, signs and symptoms that you would see would be increased pain and the patient will be unable to use the affected limb. Happens most commonly in a femoral head fracture. Okay, so I want you to be sure that you review Table 62.1 for complications of fractures on page 1077. These are going to be important issues to identify, to be able to identify. So be sure you can identify some of these issues if you were given a scenario. All right, signs and symptoms of a fracture. Pain is the most common symptom. Loss of function. Patients can't use that extremity. I have a friend whose son broke his arm, and it wasn't an obvious break, and so she was kind of like, I'm not really sure. She took him into the ER because he just really wasn't using his arm well, and that's oftentimes how you can tell, especially in younger kids, because they just won't use that arm at all. And sure enough, he did have a small break. A deformity, obviously, if you have a significant deformity like the very first picture that was on this PowerPoint, you're going to know that there's a fracture, there's a problem. False motion. So false motion is if you have an unnatural motion, an unnatural movement to things, then we may start looking at there's something's going on. There may be a fracture in there. Crepitus. Hopefully you guys remember crepitus from first semester. If you don't, please look it up. The crepitus is that popping noise. Okay, can be heard also from air trapped in the tissue. But crepitus with fractures is often that grating sound of bone moving over bone. All right, edema is another sign of a possible fracture. Excuse me, as well as spasms caused by the muscles near the fracture contracting. So, especially if a long bone is involved and you start having these muscle spasms, that affected or injured extremity, arm or leg or whatever, will look shorter than the other leg. Okay. One or more x-ray views can determine if a fracture is present and the severity of the fracture. In some cases, a CT or MRI may be necessary. Stress fractures often won't be evident for a few weeks. Remember, those are usually seen in the lower extremities from overuse in high-impact sports. Now, I don't know, whenever it was, a couple years ago when I broke both of my feet in the same year, told you about the second fracture, or the second issue caused an avulsion fracture. But the first time I injured the other foot, it was a crushing injury. So I had stacks of drywall fall down and pin my leg under it and crush my leg, my whole leg and foot. So I went to the urgent treatment center. They took x-rays and they were like, no, nothing looks broken. And I'm just like, wow, I just can't believe that. So of course the next day they call and say, well, yeah, we think the radiologist says there might be some breaks in there. So then of course I went to the orthopedic doctor, had some x-rays done, but also went and got an MRI near the end of therapy. And there were just still tons of microfractures in my foot that are too small to do anything about surgically or anything like that. And but the point being just that sometimes an MRI is necessary to actually detect the severity or where these fractures are. All right, the goal of treatment is to reestablish functional continuity of the bone. All right, treatment discussed in Chapter 61 will be things like that: traction, reduction, internal fixation, external fixation, casting, things like that. So be sure that you kind of remember all that stuff. Nursing management for fractures includes assessing for neurovascular and systemic complications. This is very important for any kind of fractures. Remember, you want to check distal. You want to check proximal too, but distal to the injury is what we're really concerned with. Administering analgesics, providing comfort measures, assisting with ADLs as needed. Preventing infection is huge. and promoting physical mobility and skin integrity. Now, depending on the fracture, if our patient is immobile, preventing constipation is huge. Okay? Why would these patients get constipation? Hopefully you remember that they may get this constipation, well, like I just said, from the immobility, depending on what the fracture is. All right, fractured femurs are most often the result from a trauma, car accidents, a big fall, things like that. Femurs have a very high risk for bleeding. So the human body has 5 liters of blood, and you can lose up to 1,500 to 3,000 milliliters with a fractured femur. Okay, so you can have a severe, you could hemorrhage from a fractured femur. The client will have severe pain, swelling, and ecchymosis, most often treated with some form of traction. Client's going to be confined to bed. The nurse implements measures to prevent complications of immobility and inactivity. We're doing pen care, diet, respiratory measures, monitoring for the constipation and trying to help prevent constipation, keeping pain management under control. All right, here is an example of a severe femur fracture here. If you can see this, and see the little chips of bone have broken off. All right, that is a significant fracture. All right, fractured hips affect the proximal end of the femur. Results from falls and affects older adults with osteoporosis mainly. The client will complain of severe pain with movement of the injured extremity, or they may not be able to move it. Hip fractures often occur at often are a fracture of the femoral neck. The injured extremity will be shortened and externally rotated. So shortened and abducted. And that's a really important thing to be monitoring for in these patients. Remember we talked about muscle contracture, muscle spasms, and discontinuity of the bone cause that shortening and external rotation of the leg. So that is a very significant sign to know that that's what's going on. A large amount of blood loss may accompany the fracture, leading to hypovolemic shock. Hip fractures are prone to non-union and avascular necrosis. If you don't remember those, we've already discussed them. Be sure you look them up and understand them. Therefore, a hemiarthroplasty is often performed. The bone will then heal around the metallic device, and the bone will be united. Nursing management includes that of a post-op client confined to bed. Be sure that you review Chapter 61 for proper body alignment for client with a hip replacement. We've already discussed that. Remember, you don't want them bending less than 90-degree angle, and the different measures that you can do to keep them from doing that bending, having the raised toilet seat so they're not sitting down too flat, making sure they don't lean over to pick up anything off the floor and things of that nature. Okay, proper alignment for hip replacement. You need to sit the patient with the hip angle greater than 90 degrees. Hip angle less than 90 degrees can cause dislocation. You can implement measures to prevent things like skin breakdown. You're going to clean when soiled, use barrier creams, turn every 2 hours, and use that abductor pillow, a pillow between the knees so that the hip doesn't fall down. Complications from hip fractures can often lead to death for elderly patients. They can get pneumonia. They can get pulmonary embolism. So it's very significant issue when an elderly client in particular has a hip fracture, which happens frequently. We can get wound infections. We need to monitor wounds in surgical sites. We need to monitor for pneumonia, do deep breathing, turn, cough, and deep breathe, monitoring for constipation, increasing their fiber intake and their water intake, providing them with stool softeners as needed. Monitoring for urinary retention. We may need to give a Foley cath. Maybe they're not getting up to pee because it hurts too bad. We're going to have to do something about that. We also need to watch muscle atrophy and contracture, so we need to get PT going and get the patient walking as soon as possible. Okay, here's a picture of the hip fracture. Right there. All right, so that finished out 62. I think I'll start another video to do some of 63. So that finishes 62.